Hello everyone, welcome to sqadia.com, the best online video learning platform available for medical graduates and healthcare professionals worldwide. I am your educator, Dr. Lare Munir Beg, and the topic of discussion today is community-acquired pneumonia. A few years back, pneumonia was one of the leading killers of mankind, but thanks to the invention of antibiotics and the improved medical healthcare, the mortality from pneumonia still is gone down drastically, but still it is one of the major causes of mortality, especially in the underdeveloped population and in the underdeveloped world. So, our topic is we're majorly going to focus on the community-acquired pneumonia in the adult population. So let's get on to it. All right. So to start off, let's define what is pneumonia. In simple words, pneumonia can be defined as the infection of the lung parenchymal tissue. Now, as we all know that the lung parenchyma involves majorly the small alveoli and the alveolar air sacs and the distal bronchioles, majorly the terminal bronchioles and the respiratory bronchioles. So these are the lower parts of the lower respiratory tract which are majorly infected or involved in the pneumonia. As we are going to go further, when we'll discuss the pathophysiology of this disease, you'll get to know more of the how this mucous membrane is produced in the alveoli and how is this inflammation, as you can see here, an inflamed bronchiole, how is this inflammation produced. So these are the major precursors which leads to the infection of pneumonia, the inflamed bronchioles and the inflammation at the level of the alveoli and the alveolar air sacs. Any problem in the upper respiratory tract that is involved starting from the nose up till trachea, we don't label them pneumonia. Pneumonia is confined to the lung parenchymal tissue. So this is important to differentiate pneumonia from the upper respiratory tract infections. Now, after this brief definition, let's go into the various ways we can classify pneumonia. Pneumonia can be classified by various ways for the ease of the discussion and for the ease of the treatment and the different modalities we can use to diagnose pneumonia. The simplest classification starting off is the anatomical one, where we define the pneumonia according to the part of the lung it infects. If the pneumonia infects a whole lobe of the lung, it is called lobar pneumonia. If there is some patchy inflammation involving the different lobes and the small bronchioles are also involved, then we define it as bronchopneumonia. And if the major part involved is the interstitium, the connective tissue along with the alveolar air sacs, then it is called interstitial pneumonia. It is also called atypical pneumonia for a few reasons, as the organisms which lead to the atypical to the interstitial pneumonia are generally different from the normal microorganisms which infect the lobar and bronchopneumonia. Another way to classify pneumonia is the etiological way, the cause of the pneumonia. We can classify pneumonia as bacterial pneumonia if bacteria are the organisms causing the infection, or the viral pneumonia if various viruses are the one that infect the lung parenchyma. A few fungi, especially in the immunocompromised patients, for example, the HIV positive or the AIDS patient, can also cause pneumonia. Today, our major discussion involves the healthy population. We are not going to go into the details of the immunocompromised state. That is for another lecture. Latest classification for the pneumonia is we broadly classify pneumonia now into two major categories: the community-acquired pneumonia or a healthcare-associated pneumonia. Why do we need to classify pneumonia according to this, the community-acquired or the healthcare-associated? This gives us a lot of insight into, by classifying pneumonia into these two variants, we get a lot of insight. For example, the common organisms, for example, the the Streptococcus pneumoniae, the Haemophilus influenzae, or the Staphylococcus aureus, and for that matter, the anaerobes, the upper respiratory tract infection, which cause the oral anaerobes or the Enterobacteriaceae, they're generally classified into the community-acquired pneumonia. These pneumonias are acquired most majorly in the community, and the other way the ease to differentiate them is because the treatment modalities needed for this community-acquired pneumonias are generally very simple. As far as this healthcare-associated pneumonia is concerned, it involves generally the hospital-acquired infections and especially the ventilator-associated infections. By classifying them as a separate entity, what helps us is these are majorly the multi-drug resistant organisms which cause these healthcare-associated infections. For example, if a patient is admitted in the ICU for a stroke or for any other illness, and if he catches pneumonia, then immediately our attention goes into that this pneumonia might be because of the multi-drug resistant Staph aureus, for example, the MRSA or the VRSA, or it can be because of the multi-drug resistant Pseudomonas. So we start our empirical treatment according to that. For community-acquired infections, our empirical treatment, as you're going to see further in the lecture, is slightly different as compared to the healthcare-associated pneumonias, or when we suspect there is some multi-drug resistant infections. We go into the more IV side of things, and also we go into more potent antibiotics, the newer generation of cephalosporins, and various newer drugs. So, all right. Now we are going into a bit more detail about the pathophysiology involving the pneumonial disease. Now this diagram at first may seem very complicated, but we are going to break it down into various small steps so that you are able to understand the different processes involved in the pathophysiology of the pneumonia. All right. So to start, before going into the description of this diagram, as we know, there are various host mechanisms, various host defense mechanisms which prevent the microorganisms or various allergens going into the respiratory system. For example, starting from up to the nose, we have the nasal turbinates and the nasal hair cells, which trap any microorganisms, or if there are some allergens which want to infect the respiratory system. They trap, and we have the mucociliary escalator, which throws them out into the environment. For example, when you sneeze, what is sneezing? Sneezing is basically your body's defense mechanism when it throws the microorganisms out of your body and protects your respiratory tract. Similarly, as we go down the oropharynx, the larynx, and the trachea, all the way up to the bronchioles, the terminal bronchioles, we have the various mucus cells which create a lot of mucus, and we have the mucociliary elevator, the various cilia which propel the microorganisms and the antigens from upwards and prevent them from going all the way up to the alveoli. The alveoli is a very important part, as we know that the major gas exchange occurs at the level of the alveoli. When you inhale oxygen, it goes into the blood by the alveolar capillary membrane. And the carbon dioxide, which your body collects, and it goes via the pulmonary arteries, the deoxygenated blood, it goes from the alveoli all the way up. We exhale the carbon dioxide from the alveoli to the respiratory tree and then outwards. So it is very imperative for the body to protect the alveoli. These all host mechanisms are the major functions which protect our alveoli and ensure that the gaseous exchange is taking place. If for some matter there are some microorganisms which are very small and they bypass these mucociliary elevator and the various defense mechanisms, at the level of the alveoli, we have the alveolar macrophages. These can be described as the guards of the alveoli or the policemen of the alveoli. If for some matter any bacteria or anything, it has escaped the upper respiratory tract and is able to reach the alveoli, then the alveolar macrophages are your safeguards. They engulf those microorganisms, and with the help of the local proteins and along with, for example, the surfactants and different proteins, they engulf these alveoli, they engulf these microorganisms and destroy them or kill them. So for the major part, most of the times, whenever we have some microorganism reaching the alveoli, it does not cause any disease because our alveolar macrophages protect our alveoli. But if for some matter we have a microorganism who is able to disarm the alveolar macrophage by its various processes, for example, we have some capsule, or example, it produces some protein which destroys the alveolar macrophage's ability to form a phagolysosome, or the alveolar, there are a lot of microorganisms infecting at a long time, at a similar time, for example, that the ability of the alveolar macrophages to disarm them is overwhelmed. Then what happens is the alveolar macrophages call for help. They release various mediators, which I'm going to describe in this diagram, which call the neutrophils and the various other cells, hematopoietic cells, which help in the resoluting this infection. So you can define pneumonia as basically the response of the alveolar macrophages. It is the inflammation which is produced by the mediators produced by the macrophages, which leads to all the signs and symptoms of pneumonia. It is not directly the microorganism involved which produces the signs and symptoms. So now, after having this background in mind, let's go through this diagram. So this is the nasal cavity starting all the way up from the larynx to trachea, and these are your lungs. So whenever a microorganism comes and bypasses all these defense mechanisms and reaches the alveoli, and it has the ability to overwhelm the alveolar macrophages. How can it do that? Well, there are different types of microorganisms, primarily the bacteria, the viruses, and the fungi. A few bacteria, for example, Streptococcus pneumoniae, they have the peptidoglycan cell wall. They have a capsule. They produce various substances which are able to disarm the alveolar macrophages. This is an alveolar macrophage. These are the various receptors which are involved in interaction. For example, this is TLR, toll-like receptors. These involved with the T lymphocytes and help in the inflammatory process. As you have gone through the acute inflammation during your pathology lectures, these are all the steps involved in acute inflammation which are taking place. So with the help of these things, lipotecoic acid, pneumolysine, DNA, peptidoglycan, for example, the gram-positive bacteria, they have the peptidoglycan in the cell wall. The DNA viruses have the DNA. The bacterial RNA is present in the bacteria, or some RNA viruses are present. Some bacteria can produce various pore-forming toxins, which are able to disarm these macrophages. So when the macrophage realizes that it is unable to fight all these microorganisms, what it does is it produces various leukotrienes. It calls for help, basically. What are the various mediators produced by the macrophages? The important ones to remember are these: interleukin-1 and TNF-alpha. What does these do? Interleukin-1 and TNF-alpha, they are the major causes, these are the major mediators which increase your body temperature to fight the infection, which causes the fever or the hyperthermia. Another very important one to remember is interleukin-8. What does this interleukin-8 do? This interleukin-8, along with leukotriene B4, it calls the neutrophil. These are the neutrophils, the multi-nuclear cells, the multi-lobar nuclear cells, which it calls the neutrophil, and then the neutrophil comes and releases various mediators and starts the process of acute inflammation and helps the macrophage in killing these bacteria. So these interleukin-8 along with the leukotriene B4, what does it do? It attracts the neutrophil, and the neutrophil goes into the alveoli, the alveolar capillary interface via these steps. The endothelial activation takes place, there is transendothelial migration, and then the chemotaxis produced by these mediators calls the neutrophils, and then the neutrophils help clear the infection. Now, if the infection is limited by the neutrophils and to the level of the alveoli, that's very good. We are able to resolve the infection. The patient gets better, and there is no further problem. But sometimes we have some very resistant strains or some very potent microorganisms which are able to bypass all these steps as well. And when they get into the blood circulation, then from this focus of infection, which is in the alveoli, they lead to the extrapulmonary dissemination via blood. And the various cytokines, chemokines, pathogens and products are involved in all these steps. And what does this do is, when the bacteria is able to spread to the various parts of the body, it leads to the endothelial dysfunction throughout the body. The endothelial of the blood capillaries is dysfunction, and after this dysfunction, there are release of the von Willebrand factor and the exposure of the subendothelial collagen. These all lead to a procoagulant state. And there is the coagulations, the body, there is diffuse coagulation throughout the body, which can lead to a condition called DIC, disseminated intravascular coagulation. Your platelets are consumed, which can lead to thrombocytopenia. And then there is exposure of the factor 7 and the tissue factors, and this cycle of procoagulant state starts. It leads to DIC. DIC can further lead to the ARDS, the acute respiratory distress syndrome, and then it can further lead to the respiratory failure, which is a very major cause of mortality. So if there is some extrapulmonary dissemination, or if there is some very potent strain or the multi-drug resistant strain of some bacteria or some viruses, then these are the things which we fear in pneumonia. These are the things which we want to prevent, and these are majorly the patients you'll find in the ICU of a pulmonary care unit, which have these states, and we are trying to help them via various mechanisms which we are going to go through further in the detail. So I hope this complicated diagram makes more sense to you now. So let's go further into after the pathophysiology, let's go a bit more into general pathology. What does it look like on a histopathological stain? Now, This, as you can see, these are the air spaces which are alveoli. Now, what you see here, these are all neutrophils. Okay, these have completely effaced all the alveolar surfaces, and the general architecture of the lung is destroyed. These are all the neutrophils which are going to get transformed, which are either going to get engulfed by the macrophages as the infection is going to resolve, or they can lead to pus cells. And this is classical lobar pneumonia involving all the parts of a single lobe. And you can see there is a bit of collagen deposition as well in the walls of the alveoli. This can lead to thickness of the alveoli, and this can lead to the difficulty in gaseous exchange as well. Now, after this histopathological diagram, this is a gross presentation of what a lobar pneumonia looks like. Look at this side. This is the normal part of the lung, and this red, slightly dense tissue is a lobar pneumonia. You can see a whole lobe is involved in this pneumonia. There are various phases in the pathology the pneumonia goes through. For example, when the infection starts, the first phase is called edema or congestion. When there is leakage from the pulmonary capillaries, the exudative fluid gets into the alveoli. The exudate is a protein-rich fluid which gets into the alveoli. Shortly after that, there is a stage which is called the red hepatization. Hepatization, hepatic as you know, is the word which stands for liver. And hepatization means liver-like. So after the blood starts leaking into the alveoli, we have the RBCs or the erythrocytes which move into these alveoli and give it a slightly red or a congested appearance. And the RBCs along with the neutrophils. Neutrophils are the major cells of acute inflammation, as we all know. They start via all these steps which we discussed in the previous slide, the transendothelial migration, the chemotaxis. These lead to the red hepatization. Look, normally the lung consistency is very soft or spongy, but this looks more like a liver or a hepatic. That's why we term this as hepatization. Okay, after the hepatization, what is the next step? When the neutrophils start, after performing their activity and mediating the acute inflammation, they start their lysis or start breaking down. We have a slightly grayish appearance in the lungs, and that part is called gray hepatization. It's not shown in the diagram, but this is the next stage, which is called the gray hepatization. And after the gray hepatization, what happens? The last step is the resolution, which involves the macrophages, which clear out all the debris and then clear out the lungs, and then the lining of the lungs is now restored. The lining of the alveoli, I beg your pardon, is restored by the macrophages along with help from the type 2 pneumocytes, which are the regenerating cells of the alveoli. This is very important to remember, that the regenerating cells of the lungs, the alveoli, are the type 2 pneumocytes, which can lead to, again, a normal lung after the infection or the pathology has resolved. So these are the basic steps involved in the pathophysiology and the pathology of the pneumonia. These are important to remember to understand how pneumonia develops, so that we can help diagnose it via various tests and then help treat them via various antimicrobials or antivirals. All right, after going through this detailed discussion of the pathology, now let's go into the various bacteria involved in the bacteria or the viruses or the microorganisms involved in causing the community-acquired pneumonia. Now, for the ease of understanding, we have divided the various organisms which cause the pneumonia into three categories. The number one are the ones are the patients which see in the outdoors or the OPDs. These are the ones which are generally microorganisms, very common in the community. So let's start off with this. Streptococcus pneumonia generally is the number one cause of pneumonia in the adult population, as you can see all through in the patients outdoor, in the patients in the hospital, in the non-ICU patients, or the patients which are in the intensive care unit. Streptococcus pneumonia is the number one cause of pneumonia in the adult population. You have to remember this. This is a very important point to remember, and this is the bacteria we are targeting primarily in the empirical antibiotics whenever we have a patient whose lab tests are awaited. Streptococcus pneumonia is the number one cause. As far as the outpatients are concerned, after the Streptococcus pneumonia, we have the Mycoplasma pneumonia, which causes an atypical or the interstitial pneumonia, as I described initially. Number three is the Haemophilus influenza. Haemophilus influenza used to be a very common cause of pneumonia, but now, thankfully, because of the advent of the vaccine for the Haemophilus influenza, the incidence of this disease has gone down, but still it is one of the major causes in the outpatients population. It can also cause epiglottitis, which can lead to further pneumonia. Epiglottitis can be a very life-threatening disease. So it is important to remember as Haemophilus influenza is a very important cause. It also causes pneumonia in the immunocompromised population. Now, the chlamydia pneumonia is also a very common cause of pneumonia, and this also leads to an atypical pneumonia. Now, so there are certain viruses which we have labeled as respiratory viruses, which generally infect the respiratory system. They can cause generally a simple flu-like state like the upper respiratory tract, the rhinorrhea, or the throat congestion, or they can further lead to pneumonias by themselves or by superimposed infections by these potent microorganisms. So what are the various respiratory viruses which we have to remember? The common ones are the influenza A and B virus, the parainfluenza virus, the respiratory syncytial virus, and the adenovirus. If you can remember all these 4 viruses, then they are the major ones which cause the respiratory tract illness. The influenza A and B, the parainfluenza, the respiratory syncytial virus, and the adenovirus. So these category of microorganisms cause the disease pneumonia which we see in the outpatients. These are not very generally, in general terms you can say, it is not very life-threatening as the patients we see in the outdoor, and they can be managed by oral antibiotics. But as we go further in the hospitalized patients, the non-ICU hospitalized patients or the ICU hospitalized patients, a lot of these bacteria can cause these diseases as well if they are multi-drug resistant or if we don't catch them at the start. So the typical non-ICU patients which we see with pneumonia, the major etiological microorganisms are again strep pneumonia, it's the number 1 cause, again the mycoplasma pneumonia, the chlamydia pneumonia, the Haemophilus influenza, especially as I told you in the immunocompromised patient, for example, someone with diabetes or HIV, influenza is a very common cause, as is Legionella. Legionella is a very important bacteria to remember because it can cause a lot of diseases in the cancer patients or patients going to the chemotherapy or the immunocompromised, the diabetics, the HIV positive. And another very important factor to remember with Legionella are the water resources. For example, if you have a patient with pneumonia who gives you a history of recent travel through a cruise or has a recent sea travel history, then Legionella is a bacteria which you have to keep in mind because it is the one which spreads via water resources. It can also spread by the water resources in the air conditioners. So this is also very important to remember. There has been various outbreaks of Legionella in various parts, sea cruises and various water resources. Again, the respiratory viruses also can infect the non-ICU patients. Now, as you go through these ICU patients, these are the patients which are very difficult to treat in medicine, normal general practice. And these are the patients which have a lot of mortality, and we try the various most recent and the potent antibiotics. Again, strep pneumonia by far is number 1. When I talk about this Staphylococcus aureus here in the ICU category, it's not general Staphylococcus aureus. Mostly it means the multi-drug resistant organism like the MRSA, methicillin resistant Staph aureus, and now recently there have been a VRSA, vancomycin resistant Staph aureus. It has also involved. So whenever we talk about community-acquired pneumonia, especially in the ICU patients, majorly we are talking about Staph aureus. Mostly we are talking about the community-associated multi-drug resistant Staph aureus, CAMRSA as it is abbreviated. Again, Legionella, as I told you before, it can also cause disease in the ICU patients. Now, in the ICU, we can also have certain gram-negative bacilli. Why is that the ICU patients have gram-negative bacilli? If you just think for a second, gram-negative bacilli majorly are the ones which are your enterics involved in the GIT or the gastro tract. So the patients in the ICU, they are bedridden, and they, for most parts, are very old and very ill patients. They have some patients have a stroke, some patients have diabetes, so their cough and gag reflex is not as potent as for a young healthy adult. So these gram-negative bacilli or the oral anaerobes for that matter, the bacteroids or the fusobacterium, they can go into the lung by aspiration. So this majorly causes the aspiration pneumonia in the patients. And we have to clear their throats from time to time. We have to aspirate the material so that they don't cause disease, and this majorly causes disease. The aspiration pneumonia majorly occurs in the right lower lobe because the right Mainstem bronchus is wider and smaller as compared to the left. So the bacteria can easily go downwards into the right side of the lung. So it causes mostly the right lower lobe pneumonia. And these are the anaerobes in the gram-negative bacilli or the Staph aureus, which can also cause empyema or abscesses, which are difficult to treat in these ICU patients. So this is a generalized classification of community-acquired pneumonia according to the etiology. All right. After going through this discussion, let's go into the various factors step by step which predispose a patient to pneumonia, some of which we have discussed before. So let's go into it. To start off with, alcoholism. Alcoholism, if a patient has been drinking for a long time, then he is predisposed to pneumonia. One of the major reasons is, for example, if he passes out after a large drink, then it can aspirate the oral anaerobes. So oral anaerobes are the ones which can cause the patient in an alcoholic. Streptococcus pneumonia is still the #1 cause of pneumonia in alcoholic patients. As you will see, it's majorly the #1 cause of pneumonia in all the population. So after Streptococcus pneumonia, we can also have pneumonia in an alcoholic caused by Pseudomonas, which is a gram-negative bacteria. And Klebsiella is another gram-negative bacilli which can cause pneumonia in an alcoholic. So basically, what alcohol does is it predisposes it decreases your immunity if you have been drinking for a long time, and it raises the chances of having aspiration pneumonia. So alcoholism is an important factor as far as pneumonia is concerned. Smoking, again, it damages your lungs. It's not good. Smoking has no single benefit to your body. It also causes an immunocompromised state if you have been smoking for a long time. And the similar microorganisms, the Streptococcus pneumonia and the Staphylococcus aureus, Haemophilus influenza, these are the ones which cause pneumonia in this population. If we have some structural lung disease like COPD or some restrictive lung disease, then these are the lung tissue which are also predisposed to cause to pneumonia, and the bacteria involved are the similar ones. The important ones to remember, apart from the common ones like Streptococcus pneumonia or Haemophilus influenza, are Pseudomonas. Pseudomonas is a very important bacteria, gram-negative bacilli, which causes disease in the structural lung tissue patients. For example, if someone has cystic fibrosis, Pseudomonas becomes very higher up in the list in the microorganisms involved in the patients involved with cystic fibrosis or some restrictive lung disease or some immunocompromised patient. So according to the patient's history or the patient's general condition, we can have an idea of what are the microorganisms involved. Definitely we'll be surely able to tell what are the microorganisms involved in the disease after we have all the labs and all that. But this gives us a general idea as to where we have to target our anti-microorganism therapy. Similarly, if someone has dementia or stroke, they are immunocompromised and they have reduced cough or gag reflexes. And this can also lead to a lot of aspiration pneumonia. In this condition, the major microorganisms involved, apart from Streptococcus pneumonia, are the oral anaerobes, the Fusobacterium, or the gram-negative bacilli, which can go all the way up from your enteric tract and cause aspiration pneumonia by aspiration from the trachea into the lung tissue, like your Pseudomonas, like your Klebsiella, for example. Lung abscess. Lung abscess can develop, especially in patients which are infected with the MRSA, the multi-drug resistant Staph aureus, or the oral anaerobes. For example, if a patient has stroke and he has aspirated an oral anaerobe into his right lung cavity, then this can lead to a lung abscess as well. And now we have to, after a lung abscess develops, we may have to drain that abscess via chest tube, or we have to give more potent antibiotics to fight off this infection. Now, the travel history is also very important. There are certain parts in the United States especially which have various pathogens associated with it, especially the fungi. For example, if you go to the southwest, there is histoplasma. In the southern eastern part, the desert part of the United States, we have the coccidioidomycosis involved. So the travel history, if a patient has had a recent travel, it can also give us an idea of the various microorganisms involved. So it is important during the history taking to have a thorough investigation, the thorough history of the patient of the recent travels, or his comorbid conditions, his smoking history, his alcoholism history, if he has some structural disease, or if he has some previous stroke episode. These are all the factors which help us in making an educated diagnosis. Similarly, the exposure to bats or the birds can also lead to some atypical pneumonias. For example, exposure to bats in the caves can lead to the histoplasma, which is a fungal cause of pneumonia. Similarly, the birds, the pigeon droppings can also cause cryptococcus pneumonia or different types of pneumonias. These are generally the atypical pneumonias, which are comparatively, we call them atypical because they lack the typical signs and symptoms, which we are going to see in the next slide, of the pneumonia, the chills, the rigors, the fever is slightly low, and the patient is generally well. But when you do the X-ray or the investigations, you know that the patient has pneumonia, but it has an atypical presentation. And it is also important to classify them as atypical because the drug therapy is slightly different as compared to the typical pneumonia. Similarly, if a patient has an exposure to rabbits or the sheep, the goat, or the cats, it is also a risk factor which can cause pneumonia, especially in the immunocompromised patient. For example, there is a microorganism called Coxiella burnetii. It's a type of a rickettsial disease which causes diseases generally the veterinarians or the farmers. Now, what happens is the spores of this Coxiella, they are present in the placenta of the cow. So if there is a veterinarian or some farmer who is dealing with a cow, he can inhale those spores and it can cause an atypical type of pneumonia, the Coxiella. We are going to read further about the detail of this disease in another lecture, but it is important to remember that the exposure to various domestic animals and the exposure to the bats, the travel history, and all these factors are important in causing pneumonia. All right, after all this discussion, as we have seen, let's go through what are the various clinical manifestations, what are the various signs and symptoms which the patient presents, which help us in tailoring the differential diagnosis, involving the pneumonia in the differential diagnosis, and it's important to rule it out. Number one, tachycardia, increase in the pulse or the heart rate. Then the patient can have chills or sweats. He has fever, cough. The cough can be non-productive without the sputum, or it can be very productive cough. It can also be a bloody cough, especially in MRSA infected patients, which causes a necrotizing pneumonia. The cough can have a lot of blood in it, and whenever a patient presents with grossly bloody cough and all the other signs and symptoms of pneumonia, the number one microorganism to keep in mind is MRSA. The patient can have blood-tinged sputum. The patient will have shortness of breath, dyspnea, because there will be pus in his alveoli and the gas exchange is not taking place, and he will have difficulty in gas exchange, or he will have difficulty in breathing. The pleura can involve in the advanced stage of the disease, and when the patient aspires, he feels the pleuritic chest pain. The pleura are unable to expand because of the thickness of the plug or the mucus plug, because of the infection. So the patient, whenever he inspires, he feels pleuritic chest pain. Now, the general symptoms of the disease, the nausea, vomiting, the diarrhea these are the general symptoms associated with any malaise like fatigue, headache, myalgias and arthralgias, and increased respiratory rate called tachypnea. The classical symptoms to remember along with these, the generalized symptoms are these: the tachycardia, the short sweats or the shortness, the chills, the fever, the cough, the blood-tinged sputum, the shortness of breath, the pleuritic chest pain, and then respiratory rate. These are the symptoms which, when the patient presents with these symptoms to us, we have to keep pneumonia very higher up in the differential diagnosis. Alrighty, talking about the differential diagnosis, let's see how we are able to confirm after our clinical judgment and various labs, confirm the diagnosis of pneumonia. Number one question is to ask after these signs and symptoms, is this pneumonia? And number two question, if it is pneumonia, what is the likely etiology? What are the various organisms involved? Now, to answer the number one question, let's go on to the next slide. The number one question, is it pneumonia, involves two steps. Number one, as I talked before in the previous slide, the signs and symptoms of pneumonia, the various chills, rigors, the increased respiratory rate, the tachycardia or the dyspnea. These are the various signs and symptoms. involved. When we examine the patient, when we examine the respiratory system, when we put a stress to these patients present majorly with consolidated lungs. So the breath sounds will be decreased, or there will be bronchial breath sounds over that part of the lungs which has pneumonia. The bronchial breath sounds are different from the normal breath sounds because they have the large expiratory phase as compared to the normal vesicular breath sounds. Again, when we percuss the chest, that there will be dullness to percussion in these patients. So these are the signs and symptoms which we can see clinically without any lab tests, which will lead to the diagnosis of pneumonia in our head. Similarly, to aid us, there is the basic chest radiograph. This can be done in the outpatient patients. So these are the two investigations these are the two things: the signs and symptoms, the clinical judgment, and the chest radiograph, which give us a major diagnosis of pneumonia in majority of the cases. To confirm this and to find out the etiology, we do the further labs which we are going to discuss further to tailor down our microorganism to the specific one. After these two investigations, after these chest radiographs, we can start the empirical therapy in the patient. And as we await the lab results, and then we have the lab results, we can tailor down our therapy to the specific microorganisms depending on the culture and sensitivity report. Now, this is the chest radiograph of a patient which presented to us in the OPD with a lobar pneumonia. As you can see, as we compare the both sides of the lung, you can see here, this is the lobe infected with pneumonia, a classical sign of a whole lobe being infected by pneumonia. So this is classically a lobar pneumonia. For comparison, if you compare it with the normal chest X-ray, look, these are the this is the normal chest X-ray with all the markings and the whole expansion. And in this patient, look, the air can't get through in this consolidated part. So this is the portion which is infected, and this is the classical chest X-ray to remember for examination as well for the lobar pneumonia. Now, after we have diagnosed a patient of pneumonia with the help of a chest X-ray, the next step is to tailor down what are the microorganisms involved in this patient causing the pneumonia. So we can target the microorganism with a specific drug. When we have a diagnosis, we start our empirical therapy, which we are going to discuss in the treatment. And then after these tests, our results come back, we tailor our therapy to the specific organism which we have got from the report. So the start of the easier ones are the gram stain and the culture of the sputum. We take a sputum sample of the patient, we do a gram stain. This helps us in diagnosing whether the patient is infected by a gram-positive bacteria or a gram-negative bacteria, or for a bacteria which doesn't appear on a gram stain, like Legionella. Legionella is an atypical microorganism, and you can't pick up Legionella on the gram stain. You have to do silver staining for Legionella and various different tests which we see. And the culture of the sputum also helps us in the diagnosis. This is all just effective for the patients who are gram-positive, or for the bacteria which are either gram-positive or gram-negative. The atypical bacteria, this doesn't help in the infections caused by the atypical bacteria, or for that matter, the viruses or the fungi involved. Again, the microorganism from the alveoli also travels in the lung, also travel in the blood and causes bacteremia, and we can have a blood culture to find out, blood culture and sensitivity to find out what is the microorganism if the gram stain doesn't help us a lot. And as you know, that these tests take a few days to come. So after the starting of the empirical therapy, when these test results are awaited, this is the period that we have to be very careful with the patient. And when we have the reports of the culture and sensitivity, we can tailor our treatment to whatever the microorganism involved. Urinary antigen test is a very helpful test, especially for two bugs, the Streptococcus pneumoniae, and very importantly for Legionella. When we do a Legionella antigen test, urine antigen test, it can be performed in the OPD. And as I say, that Legionella is an atypical microorganism. It does not appear in the gram stain. So the urinary antigen test has a lot of sensitivity and specificity to diagnose Legionella with confidence. So this urinary antigen test you have to remember for Legionella pneumonia, and it's a very important examination point as well. Now we can do the polymerase chain reaction, or it's called as it is called PCR. This is majorly helpful for diagnosing the viral pneumonias, as we amplify a portion of the DNA or the RNA of the virus. It can help us identification of the RNA or the DNA viruses, or for that matter, it can also help us in the evaluating the treatment which we are going to. If the patient is getting better, we do a PCR of the patient, we see if the viral load is increasing or decreasing. If the viral load is decreasing, then we know that our patient is getting better and our treatment is helping the patient. Blood serology, the IgM antibodies against the bacteria, we can also do this. These are very non-specific. So these are the major tests, the starting ones, which are more majorly helpful: the gram stain, the blood culture, the PCR. And in the end, the general markers of inflammation, for example, the CRP, C-reactive protein, the procalcitonin. These are the ones which don't help in diagnosing the infection. These are basically the general markers of inflammation, which help us in evaluating whether the disease is getting better. If the initial CRP of the patient is very high and we have started the treatment and we do a CRP after a few days and the CRP level goes down, this means that inflammation is resolving and the patient is getting better. So these are basically, you can see, help procalcitonin, CRP, they help us in evaluating the progression of the disease or evaluating the treatment, whether we are giving the right antibiotics and the treatment is helping the patient or not. And based on these markers, we can change our modalities. If the CRP level continues to be high, we can change the antibiotic, we can look further into the test, we can do a few different investigations. So these are all the tools which help us in making an etiologic diagnosis of the community-acquired pneumonia. Now, after we have gone through the pathophysiology and what is pneumonia and diagnosis of the pneumonia, now comes the part of the treatment. Now, the number one part before starting any treatment is we stratify the patients as to where this patient needs treatment. For example, as you know, the pneumonia can be very taxing on the medical personnel and the hospitals, because the patients can be severely ill and they can occupy the beds for a long time. So it is important for us to stratify the patients according to the disease severity, or the patient, what are the chances of mortality. If we have a patient, we have to ask our question whether this patient is severely ill, that he has a high chance of mortality. So we have developed various indices to stratify the patient according to their risk of mortality. The higher the patient's chance of mortality, we admit this patient in the hospital or the ICU, and if some patient has a lower chance of mortality and he can be managed easily in the outpatient department or for that matter at home, so we don't admit those patients. And by this stratification, it also helps us focus more on the patients which are more on the serious sides and need more treatment and need more observation. So the two indices are the pneumonia severity index and the curve 65 index. To start off, we're going through the pneumonia severity index. In this pneumonia severity index, let me first put all the markers of this severity index on the slide so that you can able to compare all these severity index. And then we are going to go through one by one through the different markers. All right, let's start from here. You can see there are four different indices according to which we classify the patient: the demographics, comorbidities, the physical exam, and the lab test. Starting with the demographics. Now, there are various points for each part, and at the end we calculate all these points, and then according to our preset criteria, we classify the patients and we calculate their percentage of mortality, and according to that we make the decision of whether we have to admit the patient in the hospital or whether this patient can be managed in the outpatient department. So for age, it varies 1 point per year after the age of 50 years. This is important to remember. So example, if someone is 60 years old, then that he gets 60 points. For males, the age corresponds to 1 point. For example, if a 60-year-old male presents to us with pneumonia, he gets 60 points. For females, we minus the 10 from the age. For example, if a 60-year-old female presents, then she gets 50 points. If the patient is a nursing home resident, he or she gets plus 10 points. Now, the comorbidities which the patient has. If patient has neoplasia, he's immunocompromised, he gets plus 30 states. If he has liver disease, for example, liver cirrhosis or hepatitis or liver carcinoma, or he gets plus 20. If a patient has congestive heart failure, he gets plus 10. If he has some cerebrovascular disease, for example, like stroke, he gets plus 10. If a patient has renal disease like chronic renal failure, he gets plus 10. On the physical examination, if the patient is in delirium or he has mental confusion, he gets plus 20. If the patient has increased respiratory rate more than 30 breaths per minute, then he gets plus 20. If the patient's systolic blood pressure is very low, then he gets plus 20 as well. If the temperature is high or very low, if there is hypothermia or hyperthermia, for example, if the patient has temperature less than 35 degrees Celsius or more than 40 degrees Celsius, then he gets plus 15 points. Similarly, if the patient is tachycardic, he has pulse greater than 125 beats per minute, we give him 15 points. For the lab test, if the arterial pH is very low, less than 7.3, then he gets 30 points. If the blood urea nitrogen is very increased, more than 30, then he gets 20 points. If the sodium is low, less than 130 milliequivalents per liter, then there is plus 20 points. If the blood glucose is very high, more than 250 milligrams per deciliter, then he gets plus 10 points. If the hematocrit is less than the 30%, then the patient gets plus 10 points. If there is pleural effusion present, then we have plus 10 points. And if the patient's oxygenation, the PO2 is very low, less than 60 millimeters of mercury, or the saturation is less than 90%, then he gets plus 10 points. After all this evaluation, we calculate and add all the points and see in which category does, according to this index, the patient falls. If after calculating the total is less than 50, then we can say that the mortality rate is less than 1% or 0.1% in this patient. This patient can be easily managed in the outpatient department or the OPD. If the score is between 50 and 70, 51 to 71, then the mortality rate is 0.6%, and this patient can also be managed conservatively in the outpatient department. After this, if the mortality rate starts going up, if the score is between 71 to 90, then the mortality rate generally is 2.8%. And for these patients, we don't admit them in the hospital settings per se. We keep them in an observational unit and we try to treat them. And majority of them get better and then get converted into this 1 or 2 category. If the patient in the observational unit gets deterioration and his PSI score gets into this range, then as we know, the mortality rates goes high, and then these are the patients which are generally admitted in the hospital or in the ICU settings. If the score is more than 130, then these are the patients who are critically ill and have a long mortality percentage, 30%, like every 3 out of 10 patients has a chance of mortality. So these are the patients who are generally managed in observation in an ICU care. The last 2 are the ones which are hospitalized or in the ICU. The first 2 are managed in the OPD, and these middle ones, the 71 to 90 ones, are the ones which are generally observed. The other criteria is the curve 65 criteria. Curve is an abbreviation. Let's break it down. The C stands for confusion. If the patient has, in this scoring system, we score from 1 to 5. These are the 5 factors, C, U, R, B, and 65. Let's go into the details of what does all these means. The C stands for confusion. The U stands for urea greater than 7 millimoles per liter. The R stands for the respiratory rate greater than 30. The B stands for the blood pressure. If the patient has systolic blood pressure less than 90 millimeters of mercury, or the diastolic blood pressure less than 60 millimeters of mercury. And the age greater than 65 gives this 1 point. So this is the curve 65 criteria. And according to this score, we also evaluate the 30-day mortality period in this patient. For example, if a patient has 0 or 1 point on the curve 65 criteria, and this patient has a lower mortality rate, roughly 1.5%, and this patient can be conservatively managed, or for that matter in the OPD, he can be managed. If a patient has 2 curve score, then his mortality rate goes way higher. It goes up to the 9.2%. It's a higher mortality rate. But still we manage this patient conservatively, majorly in the OPD, or this patient can also be admitted in a non-ICU unit of the hospital and treated under observation. For the last 3 to 5 points, if a patient has 3 or more score in the curve criteria, the mortality rate goes way high. And these are the patients which are generally admitted in the ICU and need very prompt observation and very prompt therapy. So after stratifying the patients according to their disease severity, let's look at what are the factors which we have to keep in mind in a patient who presents to us with pneumonia, which can lead to an early deterioration. Like what are the factors which a patient develops a new symptom which when a patient develops, we have to be very careful with that patient. And if that patient is in OPD or in a non-ICU setting, he has to be shifted to an ICU setting so that he can have very close observation. These are the various risk factors for early deterioration. The number one, if a patient develops multilobar infiltrates, then if the patient's saturation goes low, less than 90%, or develops hypoxemia, which is less than 60 milligrams per deciliter, or if a patient develops the severe acidosis, his pH goes less than 7.3. If a patient starts having delirium or mental confusion, he was perfectly fine yesterday, today you saw the patient is delirious. Now it's time to shift him to the ICU and look at and investigate what is the reason of his delirium, what is causing the mental confusion. If the patient's breath rate goes up more than 30 breaths per minute, he develops tachypnea. If there is hypoalbuminemia, if there is neutropenia, or thrombocytopenia. This is very important. Thrombocytopenia, as we talked before. If a patient's platelet count starts going low, then this is very important to rule out that whether there are some extrapulmonary manifestations or the patient is going towards the DIC or then the ARDS. This can be very life-threatening. These two conditions, the neutropenia or the thrombocytopenia. So these patients have to be very carefully evaluated and treated. There is hyponatremia or hypoglycemia. These are very important risk factors to remember as far as your examination goes, and also in clinical practice in pneumonia patients, or for that matter generally in any patient who presents with severe infection. And if any of these factors develop, then this patient has to be looked down very carefully. Now let's look at the various antibiotics we have and what are the various treatment modalities we have for pneumonia. If a patient presents to us in the OPD or the outpatient department, let's look at what are the factors which we are going to consider and tailor our treatment of that microorganism. If a patient is previously healthy and has received no antibiotics in the last 3 months, then the drug of choice in those patients is a macrolide. For example, a clarithromycin or an azithromycin. If a patient has resistance to, if the patient is allergic to macrolide, then we can give that patient doxycycline as well. But macrolide is a drug of choice in patients who are perfectly healthy, young individuals without any comorbidities or who haven't received any antibiotics in the last 3 months. If a patient has comorbidities or has received antibiotics in the last 3 months, then the number one drug to consider is a respiratory fluoroquinolone, specifically the moxifloxacin, the gamifloxacin, the levofloxacin. These are the respiratory fluoroquinolones. You can also add ciprofloxacin in that list, moxigami. These are the newer generation. Levofloxacin is also very effective. Or alternatively, if the patient is allergic to the fluoroquinolones, we can give that patient beta-lactam antibiotics, the penicillins, preferably the high dose of amoxicillin, or we can combine the amoxicillin with clavulanate to increase the potency of that antibiotic. And along with this beta-lactams, we add a macrolide to that treatment regime as well. Alternatively, we can also give the patient some IV and beta-lactams like ceftriaxone or cefpodoxime or cefuroxime orally as well. If there is high-level pneumococcal macrolide resistance in that population, then instead of the macrolide, we add a doxycycline regime to these beta-lactam antibiotics, or we can simply give them respiratory fluoroquinolones. The treatment remains the same for this category, but in place of adding a macrolide to the beta-lactam, we add a doxycycline. These are the outpatient therapies. Now, if the patient is admitted in the hospital and he is in the non-ICU setting, what are the various treatment modalities we have? Again, respiratory fluoroquinolones form the first-line treatment, but in these patients, we give them generally an IV antibiotic therapy to speed up the treatment, and which can further be followed up by an oral regime. So again, the antibiotics are similar: the moxifloxacin, the gamifloxacin, and the levofloxacin. Or again, we can give an IV beta-lactam drug and combine it with a macrolide, with an IV azithromycin, for example. The beta-lactams are similar. The IV ones are the ceftriaxone, the third generation cephalosporins, or the cefepime, ceftaroline, or a few newer the cefpodoxime drugs. These are the patients, these are the treatment modalities for the non-ICU. These are all the empirical antibiotic treatments. These are the treatments we start right off as we have the chest x-ray, or we do a clinical examination and the patient is diagnosed of pneumonia, and we send the labs for the further detailed etiological investigations. These are the empirical treatment we start off in those patients, and whenever we have when we have the labs back, we can tailor these antibiotics specifically to the microorganism involved. Now, if the patient is very severely ill and he has to be admitted in the ICU, then a treatment modality is as further. We have to use a beta-lactam antibiotic, and this has to be an IV antibiotic. If a patient is allergic to a beta-lactam, we can use aztreonam or fluoroquinolone as well. But an IV beta-lactam, a potent third generation, for example, a ceftriaxone is very good. A cefpodoxime is important. Cefepime can be used. A fifth generation newer one, the ceftaroline, can also be used. So this beta-lactam has to be combined either with IV azithromycin or a respiratory fluoroquinolone. These are the similar ones: the chemifloxacin, the moxifloxacin, the levofloxacin. So we give them a combination therapy of IV drugs and till the patient gets better, and then later on we can switch it to an oral treatment when the patient is out of the ICU, or we can follow up in the OPD as well. There are some special concerns as regard to a patient who is in ICU, that there are few bugs which we have to remember and carefully evaluate in ICU patients, as we talked about in the causes of the pneumonia before. These two bugs are: number one, the community-associated MRSA, multi-drug resistant Staph aureus. If we suspect this pathogen, or if after the lab reports come, this is the pathogen involved, then this has a higher mortality rate. And along with the empirical antibiotic treatment, we have to add either an IV linezolid or vancomycin to that patient. This is very important, and because these are the drugs which majorly help eradicate the MRSA. The other simple antibiotics, they won't help counter these MRSA infections. So remember these two drugs, linezolid or vancomycin. These are added when we have MRSA infection. Or if there is a Pseudomonas infection, then these are the various ways which we have to go through. These are the three different options we have. In all the three options, one thing is common. As you can see, we add an anti-pseudomonal beta-lactam antibiotic. You have to give a beta-lactam antibiotic to counter the Pseudomonas, and there are specific beta-lactam antibiotics which counter Pseudomonas. Not every beta-lactam antibiotic is helpful against Pseudomonas. These are important to remember as well. Number one is piperacillin-tazobactam combination. The number two is cefepime or imipenem, meropenem. So these are the three or four which you have to memorize. The cefepime, which is the fourth generation cephalosporin, piperacillin-tazobactam, or the imipenem, which is given with cilastatin, as you know, or the meropenem. So these are the drugs which are the anti-pseudomonal beta-lactams, and then we can combine them either with a respiratory fluoroquinolone, like an IV ciprofloxacin or levofloxacin, or we can add an aminoglycoside and azithromycin combination with a beta-lactam. The aminoglycosides can be gentamicin, amikacin, IV, or we have IV erythromycin to combine with, then this becomes a 3-drug combination as compared to the true drug. Similarly, the beta-lactam can also be combined with an anti-pneumococcal fluoroquinolone like a levo or a ciprofloxacin, along with an aminoglycoside, a gentamicin or an amikacin. So these are important to keep in mind after the culture sensitivity comes, or when we have certain risk factors which predispose a patient to these Pseudomonas or the MRSA infections. These are very important to memorize these for the examination and for general medical practice. All right. Now in the end, we have to consider a few things in a patient who presents us with pneumonia. Along with the medical antibiotics and other things, what are the important things to keep in mind? Now, this is important to keep the patient adequately rehydrated. We have to give them IV fluids, and it is important to keep the hydration level, the blood pressure of the patient normal. If a patient develops hypoxemia or it's going into respiratory distress, we can give him oxygen therapy, and he can also get assisted ventilation if he is unable to breathe on his own for a short period of time. Some patients, apart from if we are giving good hydration to the patient, some patients still have low blood pressure or have lower hydration status. In that patient, we start the glucocorticoids. They can have low adrenocortical activity. So to counter that, we give them steroids or glucocorticoids to keep them blood pressure in the normal range. So the glucocorticoids can be added to counter the inflammatory process as well, and to keep the patient well hydrated and prevent the shock developing in the patient. Now, it is very important as well to remember various complications. We just touched on a bit in the initial slides as well. If the pneumonia gets bad and the patient develops various complications, what are the various complications which can develop, and we have to remember them, and these can be very life-threatening as well. The number one is if the patient gets worse and he can go into respiratory failure, and he will then need assisted ventilation for that patient, and this has a high mortality rate as well. The respiratory failure, the patient can go into shock. The respiratory failure can also develop because of the ARDS or the DIC leading to the ARDS, which will lead to the respiratory failure or the shock. If the patient develops TIC, he will go into the shock, and we have to give vasopressors for that patient. This also has a very high mortality rate. These are very sick patients. These are the patients we fear in the ICU. These are the complications we fear that the patient develops in the ICU. So we keep the patients in a very strict observation. The patient can go into multi-organ failure, and this has a very high mortality rate again. Coagulopathy, as I talked before, the extrapulmonary dissemination can lead to a procoagulant state. This can lead to coagulopathy or the DIC, which can lead to these three major complications, which are the major killers in pneumonia: the respiratory failure, shock, or the multi-organ failure. Now, if the patient has other comorbid illnesses like he is diabetic then that can get worse. His blood sugar control can get worse, or if he has some stroke, or if he has some other neoplasia or other comorbid illnesses, these can get worse. So whenever we are treating an elderly patient or an immunocompromised patient, we have to look at the other comorbid illnesses and evaluate them, that whether the pneumonia and the general condition of the patient is disturbing his other treatment, or whether there are some drug interactions which are causing the other illnesses of this patient to get worse. So all of these factors have to be kept in mind while treating the patient. There can be a metastatic infection. The focus of pneumonia, the foci of the bacteria can go all the way from the lungs to various parts of the body. It can go to the adrenals, which can lead to shock or reduced blood pressure or reduced hydration status of the patient. A few microorganisms, specifically the Staph aureus or the oral anaerobes, whenever the patient develops pneumonia because of these microorganisms, these can cause lung abscess. So this lung abscess, then if a patient presents with pneumonia and develops a lung abscess, we have to keep these organisms very high up in the list to target these microorganisms. And then we have to look whether this abscess needs to be drained via insertion of a chest tube, or it can be conservatively managed with antibiotics. This lung abscess can also lead to a pleural effusion, which can get complicated, which can get infected, and it can become very thick that it is difficult to drain via chest tube. And if the patient then develops a complicated pleural effusion or a thickened empyema or pus in the pleural cavity, then those patients have to undergo surgery to remove these pleural effusion or go to the video-assisted thoracoscopy. These are the various important complications which we have to keep in mind while treating the patient pneumonia. We have to look at the vitals, we have to look at the various labs and whether the labs are deteriorating, whether any of these conditions are developing, and we have to act promptly in this matter. In the end, very important to know for the examination point of view and for general medical practices, how can we prevent pneumonia? Now, we have developed two vaccines which are majorly targeting the most common cause of pneumonia, which we all know is Streptococcus pneumonia. The two vaccines are the pneumococcal polysaccharide vaccine, which is labeled as PPP23. It provides protection against 23 serotypes of pneumococcus, Another vaccine, which is a protein conjugate pneumococcal vaccine, it provides protection against the 13 serotypes. Now, the difference between these two vaccines is that this vaccine is a protein conjugate, and as you know, when a vaccine is combined with the protein, this helps in also a T lymphocyte response. So when the T lymphocyte response occurs, it can lead to a generalized greater protection. You don't need to give a booster dose to these patients which are given PCV13, or these can also develop memory cells. These patients generally require more booster doses, the PPV23 patients. What are the patients in which we can give these vaccines to? The important ones to keep in mind are the infants, or especially in a winter season, who have some upper respiratory tract infection, or someone who is immunocompromised, for example, someone who has a splenectomy, or someone who is diabetic, or HIV, or the extremes of the age, generally of the patients who are older than 65 years old. We give these PCV13 vaccine to all of these patients, or if someone has diabetes, or if has neoplasia and receiving the radiation treatment, has a lower immunity, then these are the major targets of our population. So the important ones to remember are the infants, the splenectomy patients, and the older patients, specifically who are immunocompromised. As a matter of fact, anyone who is above 65, we give this PCV13 vaccine. This is important. So with this slide, we end our lecture on pneumonia. I hope you have learned something new. And if you go through your book after this lecture, this will help you in consolidating the information. And I will see you in another lecture. Thank you.